Hey everybody, this is my final exam review for NR 509. Basically what I did is I just went through the study guide, the topics, the broad topics that were posted, and looked up the information straight from the textbook and put it here. So there was a lot of information. There was almost 600 pages of reading. So it's a lot of material to cover. Not all of it is in here, but I think I got the highlights for the most part. So this is also just from the study guide, that the information in the red letters in the columns of the textbook and the appendices at the end of the chapters may include test items. And then be familiar with techniques of examinations and recording your findings for all body systems. And some test taking strategies. Don't rush, read carefully and reread the question. I know the timing is kind of hard because I think it only gives you like 2 minutes per question or something, but try to take your time as much as you can. Do the test bank questions from the end of the textbook or the online, site that's posted on the front cover of the textbook, because I think, a pretty good portion of the midterm exam questions were either, from that test bank or pretty similar. And it also gives you kind of an idea of the question styles that you might encounter. Don't select all that apply. I think in Exemplify, you have to watch out for this. So make sure in the midterm, it won't let you select more than are actually correct. So if there's only 3, that might be a clue. And then the elimination tool, you can cross out the wrong answers to kind of help narrow down if you're using a guessing strategy. If you definitely don't know the answer, try to use the context clues to guide you. Try to answer the question before you read it. If you can answer it and your answer is an option, then that's it. And then avoid fact traps. So then, an answer might actually be true, but if it's not answering what you're being asked, then that's not the correct choice. And then watch out for switchbacks, although nonetheless, words like that, because those are sometimes used to trick you up. So make sure you're reading those closely. And then, so beginning with chapter 1, the breast and axilla, it went over the anatomy, and I did try to put page numbers here for you guys in case you want to go back and reference it. But the areola has the Montgomery glands, which are sebaceous glands, sweat glands, and accessory areolar glands. And the breast is attached to the skin by the suspensory Cooper ligaments. And then occasionally one or more extra supernumerary nipples may appear along the milk line. So you might even see those like on the torso or on the back. They're usually benign, but they're treated if there's cosmetic concerns or a possible pathology. And then in the axilla, there's 3 important nerves: the thoracodorsal, long thoracic, and intracostobrachial. And then the lymphatic drainage of the breast is important in the spread of carcinoma. So a lot of times people will present with breast cancer, with nodules in one of those lymph nodes. So the axillary lymph nodes are 6 groups. There's the anterior pectoral, the posterior subscapular, the central group, which contains Roeder's nodes, the apical, the terminal group, and the intraclavicular deltopectoral. I don't think you need to necessarily know like all the lymph nodes. I think maybe the biggest thing to know is that the lymphatic drainage is important for carcinoma spread. And then the male breast is usually a thin disc of breast tissue, and it's primarily ducts. It's not really like adipose tissue or anything like that. Some men can develop gynecomastia, which is a proliferation of palpable glandular tissue more than 2 centimeters. And some causes of this are increased estrogen, decreased testosterone, and medication side effects. Very rarely do men get breast cancer. So some common or concerning symptoms that you might see with the breast and axilla is a breast lump or mass. Lumps range from everything benign to like cysts to invasive adenocarcinoma. Breast discomfort or pain, which is mastodynia or mastalgia. It's typically not breast cancer. And then it's had to determine whether it's diffuse, which is more than 25% of the breast, or focal, which is less than 25% of the breast. And then nipple discharge. So there's physiologic, which can be due to pregnancy, lactation, sleep, or stress. And then pathologic, so galactorrhea is discharge of milk not related to lactation. And it's commonly seen in hyperprocalcitemia or hyperprocalcitoma. And then Paget's disease of the breast, it's usually a bloody discharge. Techniques of examination. So in menstruating patients, it should be done 5 to 7 days after the onset of menstruation because the breasts swell and become nodular prior to menses. So you might be more likely to, find something that's not relevant. And then adopt a standardized approach, so systemic up and down search pattern, circular with the finger patterns and finger pads. And then in women, inspect the breast in 4 views. So with the arms at the side, arms overhead, arms on the hips, and leaning forward. And you should look for skin appearance, size, symmetry, contour, and nipple characteristics. And then palpate the breast for consistency, tenderness, nodules, nipple for color, consistency, and any discharge. Inspect the axilla for rash, irritation, infection, pigmentation, and then palpate the axillary lymph nodes for size, shape, tenderness, and mobility. Breast cancer in women is the most common cancer diagnosis. The risk is increased with age, which is 80% after age 50. Also increased risk with first-degree family members with breast cancer, especially if there's 2 or more at an early age. Genetic mutations, personal history of breast cancer, or lobular or ductal carcinoma in situ. Preventing breast cancer, so making sure, healthy lifestyle choices, getting enough physical activity, diet rich in fruits and vegetables, limiting alcohol. The textbook assessment for possible breast cancer, so it gave like a little description of an assessment finding, and it said single firm, 1 by 1 centimeter mass, mobile, non-tender, with overlying peau d'orange appearance in the right breast, upper outer quadrant at 11 o'clock, 2 centimeters from the nipple. So that peau d'orange, I actually had to look that up, but that's basically like dimpling of the skin, like how an orange has kind of like little divots in the skin. So that's kind of what it might look like. And then the location of masses is typically described in a clock fashion. So if you're looking at the breast, it goes to like a normal clock face. So with breast cancer screening, so screen women for the BRCA gene if they have family history of breast, ovarian, tubal, or peritoneal cancers. And if they have a positive BRCA gene, then a lot of times these women are offered prophylactic mastectomies, which results in an 80 to 100% reduction in incidence and mortality of cancer. And then high-risk women can also take SERMs, which are selective estrogen receptor modulators, such as tamoxifen and raloxifene. They do come with an increased risk of thromboembolic events such as stroke or PE. And mammograms. So the normal recommendation is a biennial mammogram, which is every 2 years for women 50 to 74 years old. There's no evidence to screen over the age of 75. And then higher risk women should begin screening between the ages of 40 and 49. women who are at high risk should be instructed on breast self-examination. The textbook said that the USPSTF and the American Cancer Society recommends against teaching breast self-exam, but supports breast awareness, which was kind of a shock to me because I always heard, you know, growing up, like monthly breast exams, but apparently they have changed that recommendation because a lot of the findings were not cancerous. And so, but definitely, you know, if patients see something abnormal or concerning, they should bring it to the provider. There's a couple other types of screening. So there's the MRI, ultrasound, or a DBT, which is the digital breast tomosynthesis. Those two aren't needed if the mammogram is normal and if the patient's not high risk. And MRI is sensitive, so it can pick up a lot of findings, but not specific to breast cancer. So you might come up with something on an MRI, but it might not necessarily be breast cancer. But mammograms are honestly the gold standard in breast cancer screening. And then it says that you can use an MRI, ultrasound, or DBT to further assess any findings on mammograms. So, and then this is right from the textbook. This is just the different types of breast masses. So, like fibroadenomas are usually younger women, ages 15 to 25, but they can appear up to the age of 55. And then it says, you know, like there's only usually one, maybe multiple. They're round, disc-like, or lobular, maybe soft, but they're usually formed and then well delineated. And then cysts are typically found in women ages 30 to 50, and they regress after menopause, except for with estrogen therapy. They can be single or multiple. They're usually round. They can be soft to firm, but they're usually elastic and well delineated. And then cancer is usually found in women ages 30 to 90, mostly over the age of 50. The number is usually single, but may coexist with other nodules. They may be irregular or stellate. Consistency is firm or hard, and they're not clearly delineated from surrounding tissues. So I would just be familiar, you know, with how these are described, because I could see on an exam question like them giving you a description of, you know, like a firm, irregular nodule, and so where do you suspect? Okay, so moving on to the abdomen, common or concerning symptoms are abdominal pain, indigestion, nausea, vomiting, hematemesis, difficulty swallowing, which is dysphagia, or painful swallowing, which is odonphagia, change in bowel function, diarrhea, constipation, jaundice, even urinary symptoms, dysuria, suprapubic pain, urgency, frequency, polyuria, incontinence, flank pain, and ureteral colic. So going specifically into abdominal pain, so there's a couple types of abdominal pain. So visceral pain is not specific, it's difficult to localize. And then, you know, being familiar with the different quadrants. So the right upper quadrant is usually the biliary tree, gallbladder, liver. Epigastric could be stomach, duodenum, pancreas. Peri-umbilical can be the small intestine, appendix, or proximal colon. And then the hypogastric, which is, you know, below the belly button, is usually the colon, bladder, or uterus. And then there's suprapubic or sacral pain, which is typically the rectum. And then the other type of abdominal pain is somatic or parietal pain. And this is usually seen with peritonitis. And this is caused by an inflammation of the peritoneum. It's difficult, it's localized and diffuse. So you can usually pinpoint a specific location, but it may be kind of just all over. And it's typically described as an aching pain, and it's aggravated by moving or coughing. And with this, the patients will have involuntary guarding, rigidity, and rebound tenderness. And hernias, I think, are super important. And these are the signs that you can do to test for different sites of abdominal pain. Most of them are for appendicitis, but Murphy's sign, which is pain on the palpation of the right upper quadrant, is specific to cholecystitis or the gallbladder. And I always get these confused, but Murphy's sign and McBurney's sign, but Murphy's sign is the gallbladder and McBurney's sign is the appendicitis. And so with McBurney's sign, it's right lower quadrant tenderness, and then gave the anatomical description of that halfway between the umbilicus and the anterior iliac spine. And then Rausing's sign is when you press on the left lower quadrant and it produces pain in the right lower quadrant. And then the psoas sign is when you place the hand right above the patient's knee and ask them to raise their knee, and that causes pain. Basically, the movement of the knee is irritating, the peritoneum or the appendix and causing pain. And then the obturator sign is less helpful, but it's also used to diagnose appendicitis. And this one is when you do internal rotation of the hip, the right hip produces pain. And again, that's just due to inflammation of the peritoneum. So just be familiar with all of those. And then inflammatory bowel disease is usually symptomatic with bloating. And this is, it said it's a diagnosis of exclusion. So it requires intermittent pain for 12 weeks of the previous 12 months with relief of pain by defecation. And then it also includes a change in frequency of bowel movements or a change in form of stool. And so the biggest types of inflammatory bowel disease are Crohn's disease and ulcerative colitis. And so with Crohn's disease, you get the fissures and the cobblestone appearance of the colon. And then with ulcerative colitis, you actually get little ulcers forming within the mucosa. Colorectal cancer, concerning symptoms are, small caliber stools. That's usually because there's a mass in the colon. And so the stool has to kind of squish down to make its way out. Change in bowel habits with a palpable abdominal mass. So, they come in diarrhea or constipation and they have a mass, then it could be concerning for colorectal cancer. Risk factors include increasing age, adenomatous polyps, inflammatory bowel disease, and then family history of colon cancer, especially in first degree relatives or multiple relatives. And then there was quite a few screening recommendations, but the age is usually 50 to 75. And so there's the stool-based test, the fecal occult blood test, or the fecal immunochemical test. So the fecal occult blood tests are done annually, and the immunochemical ones are done every 1 to 3 years. And then the direct visualization tests are like the colonoscopy, sigmoidoscopy, and the CT colonography. I think the colonoscopy is the most common one, but that's every 10 years between the ages of 50 and 75. And then if they're older than that, if they're 76 to 85, then it's individualized decision making, based on their risk factors. If they have a lot of risk factors, then they may warrant an additional colonoscopy. But age older than 85, the recommendation is not to screen, probably because there's no prolonging life benefits for that age group. And then, okay, so chapter 20 is the male genitalia. The biggest thing in this one was the hernias. And so this is when loops of bowel come through the openings in the anatomy. And there's a couple of big types, and especially in the males, is the inguinal hernias. So there's direct versus indirect. And your basic landmarks for inguinal hernias are the anterior superior iliac spine, the pubic tubercle, and the inguinal ligament. There's two other landmarks that aren't palpable from the outside, and that's the inguinal canal and the internal inguinal ring. And then femoral hernias can often be an emergency. And the landmark there is the femoral canal, which includes the femoral vein, artery, and sheath. And then you usually need to do an ultrasound and a surgical consult for those. And then this picture shows though too, there's additional types of hernias. So it shows the indirect and the direct and the femoral, but people can also get, umbilical hernias at the belly button, or epigastric, like just above at the top of the abdomen, and then incisional, if somebody has like a open surgical incision and then like coughs or something, sometimes the bowel can pop out through there. So, but mostly in the textbook, it focused on the direct inguinal, indirect inguinal, and then femoral. So common or concerning symptoms that you might see with the male genitalia are penile discharge or lesions, scrotal or testicular pain, swelling or lesions, and sexually transmitted infections. And then the key components of the examination are to inspect the skin, a preface, and the glands for scars, ulcers, and nodules. Inspect the urethral meatus for discharge, milk the shaft if needed, palpate the shaft of the penis for induration or tenderness, palpate each testes, including the epididymis and the spermatic cord for presence, size, shape, symmetry, tenderness, masses, and nodules, and then perform special techniques as needed, which is to evaluate for hernias and scrotal masses. So scrotal masses, so if it's a hernia, do not try to reduce it if there's nausea and vomiting, because it could be strangulated. And then if you can place your fingers above the mass, it's not likely a hernia, it could be a hydrocele. And then during the Valsalva, when you have the patient bear down, if the diameter of the spermatic cord increases, it's probably a varicose. And then scrotal masses can be evaluated with transillumination. So masses that illuminate are likely a hydrocele. If it contains tissue or blood, like it's a tumor, hernia, or the actual testes, it won't illuminate. So there's that. And then testicular cancer is rare and usually curable. The risk factors are cryptorchidism, which is an undescended testicle, family history, Klinefelter syndrome, and HIV infection. And there's no routine screening recommendations for testicular cancer. There was a section in the book that talked about testicular self-exam, but it was similar to the breast self-exam in that, it's not recommended to do it like on a monthly basis, but more like self-awareness. And then female genitalia. So common or concerning symptoms include menarche and menstruation, abnormal bleeding, menopause, pelvic pain, acute and chronic, vulval vaginal symptoms, STIs, sexual health, and pregnancy. Abnormal bleeding definition, so polymenorrhea is less than 21 days between menses. Oligomenorrhea is infrequent bleeding. Menorrhagia is excessive flow. Metorrhagia is bleeding in between menstrual cycles. And then postcoital bleeding, which it said in that it could be due to like an infection or mass, but a lot of times too, it was seen in older women with like vaginal atrophy. And then so dysmenorrhea causes include adenomyosis, which is endometriosis of the muscle of the uterus, and then pelvic inflammatory diseases and endometrial polyps. Oh, and there it is. So postcoital bleeding can be cervical cancer or polyps, or in older women, atrophic vaginitis. And then the cervical exam, which, I'm sure we all got familiar with at the immersion. But for the pap smear, the patient should not be menstruating, and they should avoid intercourse, douches, tampons, or creams for 48 hours before. Cytology for all women, and then for women younger than 26, usually chlamydia will be sent also. And then cells are collected from the transformation zone of the cervix. And then chlamydia, gonorrhea, and herpes will often show as a mucopurulent cervicitis, which is a yellow discharge on the endocervical swab. And then raised, friable, or lobes, wart-like lesions are seen with condylomata, which I believe are just genital warts, and cervical cancer. And so cervical cancer risk factors, HPV is found in almost all cervical cancers. And then inadequate pap smears, like not being done frequently, you know, like if a woman doesn't get a pap smear for like 20 years. Immunosuppression, long-term oral contraceptive pills, tobacco smoking, and chlamydia infections are all risk factors for cervical cancer. And so the screening guidelines are for a pap smear from the ages of 21 to 65. For 30 to 65-year-olds, they could get a pap smear plus HPV testing every 5 years. And then in screening at the age of 65, if they've had 3 negative pap smears, with the most recent pap smear being within 5 years, you don't need to do any more screening. And then it's not recommended after hysterectomy with removal of the cervix, because you wouldn't be able to do that. The HPV vaccine is a routine vaccination for males and females beginning at 11 to 12 years. If they're less than 15 years old, then they can get 2 vaccines within 6 to 12 months of each other. But if they're ages 15 to 26 or immunocompromised, then 3 doses are recommended. And it's also recommended for women ages 27 to 45 who are at risk of infection, you know, like sexually active. Condoms do not eliminate the risk for HPV. And then it can also prevent oral and anal infections with HPV. It only covers 9 strains. I think there's like 13 or 16 strains of HPV, and the vaccine is really only effective against 9 of them. But again, it's very helpful in reducing the risk of cervical cancer. And then types of vaginal discharge, I would look at this table in your textbook on page 721. So it goes over the 3 most common types, which is this trichomonas vaginalis, which is typically a yellow, green, or a grayish color, possibly frothy. The symptoms are typically pruritus, pain on urination, and dyspareunia, which is pain with intercourse. And then Candida albicans is like a yeast infection, so it's white and curdy, thick, not malodorous. And with this, you usually have severe pruritus, vaginal soreness, skin inflammation, and dyspareunia. And then with bacterial vaginosis, it's like a gray or white, thin, malodorous, usually fishy or musty. And then the vulva and vaginal mucosa actually appear normal. So it's just a bunch of discharge, but it's not really irritating at all. And then adnexal masses. I saw this come up a couple times, but there's basically 4 types of adnexal masses, which are masses of the ovaries. So the common ones are ovarian cysts and ovarian cancer. So cysts or tumors can be on one or both sides. Uncomplicated cysts are usually non-tender. Ovarian cancer usually presents in the advanced stage. So by the time you find a mass there, it's probably spread pretty far. And then pelvic pain, increased abdominal size, and often a palpable ovarian mass. And then polycystic ovaries syndrome. This comes with the diagnosis. You have to have at least 2 out of the 3 symptoms. So ovulatory dysfunction, androgen excess, which presents as hirsutism, which is the facial hair, acne or alopecia, and confirmation of polycystic ovaries by ultrasound. And then this is typically associated with obesity, metabolic syndrome, impaired glucose tolerance, And then continuing on with the adnexal masses, ectopic pregnancy, including rupture. So this happens when there's an implantation of a fertilized ovum outside the endometrial cavity, and it's usually in the fallopian tube. If they rupture, then the patient can go into shock, like pretty severe shock, and almost bleed to death. Abdominal pain, adnexal tenderness, and abnormal uterine bleeding are the findings you'll see with this. And then a palpable adnexal mass that is large, fixed, and ill-defined. And so again, I think a lot of times in test questions, they give you these, these definitions, and they use this kind of verbiage to describe it. And so that can help narrow it down. So somebody has a palpable adnexal mass that is large, fixed, and ill-defined, and you should be thinking ectopic pregnancy. And then the other thing that can cause adnexal masses is a pelvic inflammatory disease, which is usually caused by an STI or bacterial vaginosis. And with this, they kind of have all over tenderness. So it's adnexal, cervical, uterine compression tenderness. And then you'll see purulent discharge of the cervical os. Okay, and then on to the anus, rectum, and prostate. So common or concerning symptoms are change in bowel habits, blood in the stool, pain with defecation, rectal bleeding, anal warts or fissures, weak urinary stream, change in urinary habits, burning with urination, and blood in the urine. And so for examining that, the anus sideline is preferred, and you should inspect the sacrococcygeal and perianal areas, inspect the anus for lesions, mass, or skin breakdown, and then the digital rectal examination. So the first part is you assess the anal sphincter tone, and then you palpate the anal canal and the rectal surface. And then in persons with a prostate, you'll palpate the prostate gland, noting the size, shape, mobility, consistency, nodule tenderness. And then if you have anorectal pain, tenesmus, which is the like spasming, and then discharge or bleeding, it can suggest proctitis. And that's just, inflammation of the rectum. And so causes of proctitis include inflammatory bowel disease, STIs, trauma, or bacterial infections. And then if you're unable to examine the external sphincter or the rectal vault because they're spasming too much, then it's typically an indication of infectious prostate. And then prostate cancer. So the risk factors are age, ethnicity, and family history. African Americans that have the highest incidence and mortality of prostate cancer. And then diets high in animal fat, smoking, and obesity, but there's less evidence for that, but it's still, a possible risk factor. There's no real prevention for prostate cancer. There's no real diet or lifestyle modifications that have been shown effective in prevention. The symptoms, are difficulty urinating, having to get up in the middle of the night, go to the bathroom, burning with urinating, or blood in the urine or semen. And then, so screening for prostate cancer, the prostate specific antigen is a blood test that you can do. It's important to use signal cutoffs in order to reduce the risk of overdiagnosing. There's little evidence the PSA reduces prostate cancer mortality, and so it's not done routinely. It's a shared decision making with the provider. So you may start screening at the age of 55 and then stop screening at age of 69, or if the life expectancy is less than 10 years. Musculoskeletal system. So common or concerning symptoms are joint pain, neck pain, and low back pain are the big ones. And then there's a couple different types of joints. So there's the synovial, which are freely movable, like the knee and the shoulder. And then there's the cartilaginous, which are slightly movable, like the vertebral bodies and the symphysis pubis. And then there's the fibrous, which are completely immovable. So the joints are where two bones meet. So, you know, in the skull, your skull bones don't move. So those are fibrous joints that kind of hold those bones together. Joint pain. So generalized muscle aches and pains are myalgias. And then arthralgia is joint pain without evidence of arthritis. Pain in a single joint, such as injury versus like, you know, an osteoarthritis or something, which is in multiple joints. And then larger joints, like the knees, hips, wrists, neck, and lower back are indicative of osteoarthritis, and the pain is worse with activity, better with rest. And then smaller joints, like in the wrist, fingers, and toes, are more likely like rheumatoid arthritis or lupus. And in rheumatoid arthritis, rest makes the pain worse. And, you know, because the joints get stiffer, and so it improves with activity, kind of releases some of that pressure. And then the techniques of physical exam for the joints, they gave two different ways to do it. So there's the inspection, palpation, and joint motion. So look, feel, move. Or there's this IPROMS, which is inspection, palpation, range of motion, and special maneuvers. You guys are at the immersion weekend and the orthopedic class. Most of what he was going over in that class is special maneuvers. There's a lot of them. I think the musculoskeletal chapter was probably the longest out of all of them. So because there's so many joints and so many bones, there's just so many maneuvers. I don't think it's possible or even really necessary to know them all for this exam, but you know, I would at least maybe kind of look at them and kind of get an idea of what some of them look like. And then as far as the physical exam, you should also assess for inflammation, tenderness, redness, neurologic and vascular integrity with sensation and checking the pulses. And then the shoulder joint. So atrophy of the supraspinatus and the infraspinatus with increased prominence on the scapular spine can appear within 2 to 3 weeks of a rotator cuff. So you should assess for scapular winging, and that's when the scapula kind of jets backwards. So it could be muscular dystrophy or injury to the thoracic nerve. And then compare the strength of the trapezius muscles to decide if weakness is what's causing the scapular winging. And then range of motion of the cervical spine. So there's a bunch of different muscles here in the neck. I think most of them are kind of, you know, obvious where they're located. The sternocleidomastoid, obviously we know, is like on the side of the neck. And so for flexion, you have the sternocleidomastoid, the scalenes, and the prevertebral. And then the extension is splenius, capitis, and cervicus. And then for rotation, it's mostly just sternocleidomastoid. And then for lateral bending, it's the scalenes. And then a lot of these ones of the, I can't even say, have words that clue you into that it's the spine, like the erector spinae or the spinalis. But so this is just going over the muscles that are involved for range of motion of the back. So flexion is the psoas, lumborium, and abdominal muscles, which are the obliques and rectus abdominis. And then extension, you know, to stand back up, you use the erector spinae, iliocostalis, and spinalis. And for rotation, it's usually the abdominal muscles and the intrinsic muscles of the back. Lateral bending, abdominal muscles, and intrinsic back muscles. And so decreased spinal mobility is seen in osteoarthritis and ankylosing spondylitis. So osteoporosis is decreased bone density that increases with age. The bone density doesn't increase in age, like the incidence of osteoporosis increases with age. Sorry, that didn't make sense. But half of all postmenopausal women sustain an osteoporosis fracture during their lifetime. Vertebral deformities and fractures can lead to chronic pain and disability. And then osteopenia is low bone density, but not quite osteoporosis, but it is a risk factor for developing osteoporosis. And so some of the risk factors are, postmenopausal women greater than 50 years old, low BMI, low dietary calcium or vitamin D deficiency, tobacco and excessive alcohol use, immobilization or inadequate activity, and diseases like celiac, renal, anorexia, autoimmune. And a lot of those are because of their vitamin deficiency, like when people have renal disease, they have problems with calcium. Or in celiac, you can't absorb calcium through the intestinal tract. So having those diseases puts you at risk for osteoporosis. And then medications like chronic steroid use, methotrexates, and it said PPIs, I guess. So screening for osteoporosis, women greater than 65 years, and then if the woman is younger, but they have a high 10-year fracture risk, then they should be assessed also. There's screening tools that were in the textbook listed, like online calculators to calculate osteoporosis risk. But anyway, it's measured with a DEXA scan, which is an X-ray of the femoral neck and lumbar spine, which provides a T-score. And so with osteoporosis, the T-score is less than -2.5. And with osteopenia, it's a T-score between -1.0 and -2.5. And we treat osteoporosis by giving vitamin D and calcium as like a preventative measure, and even after it's diagnosed. But biphosphonates are the first line treatment for osteoporosis as far as pharmacologic treatment. And then arthritis. So there was a couple different types here. So osteoarthritis, in the hands, you'll see these Herbeden nodules on the dorsolateral DIP, which is the distal interphalangeal joint, and then Bouchard nodes on the proximal interphalangeal joint. And they're usually hard and painless, and they may develop deformities of the hands. So they're usually just these hard lumps all over the joints. Whereas with rheumatoid arthritis, they'll be tender, painful, stiff joints, and then it causes swelling in the synovial tissue and tissue sheets. And it's usually symmetric, so it's on both hands. And then the DIP, MCP, which is the metacarpophalangeal, and the wrist are the most frequent sites for acute rheumatoid arthritis. With chronic rheumatoid arthritis, you get a swelling and thickening of those joints, and it causes like swan neck deformities, which is where the fingers really get kind of curved and stuck in that position. And you'll also see rheumatoid nodules, which are just like little tiny bumps over the joints. And neck pain. So mechanical neck pain is usually presenting like an aching pain. It involves the cervical paraspinal muscles, and it's usually present for about up to 6 weeks. It doesn't radiate anywhere. There's no paresthesias, no weakness, but they can develop this torticollis, which is like a crooked neck. There's a picture of it there. So if they've got pain for quite some time, they're probably like trying to almost guard their neck in a certain position, and it'll kind of get stiff there in a fixed position. And then mechanical neck pain, which is whiplash, is aching, paracervical pain, and stiffness, and it typically begins one day after injury. And it's usually associated with occipital headache, dizziness, and fatigue. And if it lasts longer than 6 months, it's chronic whiplash. And so some different types of neck pain continued. There's cervical radiculopathy, which is nerve root compression. And with this, you'll get a sharp burning tingling pain, and it'll be in the neck and usually like down an arm. And then associated weakness that follows a neurologic or dermatomal pattern. And then cervical myelopathy, which is cervical cord compression. You'll get neck pain with bilateral weakness and paresthesias in sometimes both the upper and lower extremities. Urinary frequency, hand clumsiness or subtle gait changes, and then neck flexion exacerbates the symptoms. And then back pain. So some red flags for back pain are ages less than 20 years old or greater than 50 years old, history of cancer, unexplained weight loss, fever, or general decline in health, pain lasting more than 1 month, or not responding to treatment, neurologic deficits or lower extremity weakness, pain at night, and persistent with rest, history of IV drug abuse, addiction, and immunosuppression, presence of active infection or HIV, long-term steroid use, saddle anesthesia, which is kind of when you have like numbness of the bladder area, and then bladder incontinence. A lot of these can indicate cauda equina syndrome, which is a surgical emergency. So that's like the saddle anesthesia, neurologic deficits or lower extremity weakness or incontinence. Those are typically seen with cauda equina. And then like history of IV drug use or presence of active infection, they might be developing like an abscess on the spinal cord or something. So things to watch out for and investigate further if the patient has these. And then these are some elbow pathologies. So this olecranon bursitis, it's just basically like a swelling and sometimes fluid accumulation at the bursa of the elbow. And it's usually due to trauma, gout, or rheumatoid arthritis. The swelling is superficial, but it may reach out to 6 centimeters, and you can consider aspiration for diagnosis and symptom relief. And then rheumatoid nodules, you can see these like little tiny bumps everywhere. There's subcutaneous nodules at the pressure points along the extensor surface of the ulna. They're usually firm and non-tender, and they're not attached to the overlying skin, but instead to the underlying periosteum of the bone. And then epicondylitis, there's 2 different types. So there's the lateral epicondylitis, which is the tennis elbow. And so you have pain and tenderness over the lateral edge, which is, the outer corner. So this has increased pain with extension of the wrist against resistance. And then the medial one, or golfer's elbow, they have pain and tenderness over the medial part, and the wrist flexion extends the pain. So those are those. Moving on to the nervous system. So the brain has 2 halves, the cerebral hemisphere, and each hemisphere has 4 lobes: the frontal, parietal, temporal, and occipital, the spinal cord, and then the peripheral nervous system. You have the cranial nerves and then the peripheral nerves. And then, so common or concerning symptoms are headache, dizziness, weakness, which can be generalized, proximal or distal, numbness or absent sensation, seizures, fainting or blacking out, tremors, or involuntary movements. And okay, so the cranial nerves, hopefully we're all familiar with them after doing the video assessment stuff. I'm pretty sure we got this all down. The only thing I wanted to bring up is that, it's weird because in the video, it had us check pupillary constriction as part of the optic nerve, but in the textbook, it lists pupillary constriction as cranial nerve number 3. So just to point that out. And then I think we see here on the next page, I put some kind of common cranial nerve problems. So with like, I didn't do all of them, but just like the highlights. So with cranial nerve number 1, the olfactory nerve, you'll have loss of smell with sinus conditions, head trauma, or cocaine use. Cranial nerve number 2, you'll have visual field deficits, which could be a stroke, you know, if they have like where they can only see out of like half their eyeball or out of only one side. And then if they have problems with visual acuity, like doing the Snellen eye chart, it could be many causes, glaucoma, neuritis, retinal emboli, sorry. And then cranial nerve number 3, sometimes you'll get nerve palsy, or with an aneurysm, you'll see the pupils are unequal. And then you also get lid ptosis, which is when the, you know, the upper eyelid is kind of droopy, and that's due to cranial nerve number 3 palsy. And then cranial nerve number 4, the trochlear, you get kind of deficits with this with myasthenia gravis, trauma, or thyroid. And if you have nystagmus, which is when the eyes kind of go back and forth, it could be cerebellar disease, or even like something metabolic, drug-induced, something like that. And then cranial nerve number 5 is usually pontine lesions that will cause deficits in this. And then Bell's palsy, if you have a peripheral vision, so sometimes people come in with Bell's palsy and you're worried that they've had a stroke because they've got kind of like facial drooping. But if it's a peripheral lesion, you'll see palsy of both the upper and lower face. And if it's a central lesion, you'll mostly just see it in the lower face. And then cranial nerve number 8, you'll have hearing loss or vertigo. The hearing loss may not be neurologic at all. It may actually just be, you know, like the typical normal hearing loss. And then the spinal reflexes. This was just showing like where these originate in the spine. So the triceps reflex originates at, you know, C6 and C7. The brachioradialis is at C5 and C6. The biceps is C5 and 6. And then the knee actually originates at the lumbar 2, 3, and 4 spots. And then the ankle is at the sacral reflex. But you must have all of, you know, everything has to be intact in order for the reflex to occur. So you have to have sensory nerve fibers, spinal cord synapse, motor nerve fibers, neuromuscular junction, and muscle fibers. So if you don't get a reflex, there's a couple, you know, different places that it could, like, is it occurring at the spinal cord, or do they just have like peripheral nerve damage? So it takes some investigating. And then, so there's a scale for grading reflexes. So a 4 is very brisk with clonics. So it's kind of almost like twitching. And then 3 is brisker than average, but not necessarily abnormal. And then 2 is average or normal. 1 is somewhat diminished. And then 0 is no reflex whatsoever. So hyperreflexia, which is like this grade 4, will sometimes be due to CNS lesions in the descending corticospinal tract. And so you'll want to look for weakness, spasticity, and or a positive Babinski reflex. And then with hypoactive or absent reflexes, those occur in the peripheral nervous system, affecting the spinal nerve roots. And then so look for associated lower motor neuron findings, such as weakness, atrophy, or fasciculations. And then headaches. So there's primary headaches, which are, you know, migraines, cluster, trigeminal, or chronic daily headaches. And then secondary headaches, which are coming from another cause, usually like a mass or hemorrhage or meningitis. And every headache should be evaluated for a life-threatening cause, such as meningitis, subarachnoid hemorrhage, or mass. And a subarachnoid hemorrhage usually presents as like the worst headache of my life, and with instantaneous onset, not like gradually over a couple days or something like that. And then atypical presentations of migraine maybe a stroke, especially in women taking oral contraceptive pills, because they're at higher risk of thromboembolic events. If a headache is severe and sudden onset, then consider subarachnoid hemorrhage or meningitis. And then new and progressively worsening headaches, maybe a tumor, abscess, or lesion. And then always take a thorough exam and history whenever somebody presents with a headache. And then this is just like a mnemonic to go with migraines. So they're usually pulsatile or throbbing, 1 day in duration or somewhere between 4 and 72 hours, unilateral. And then they often come on with nausea or vomiting, and then they're disabling, so they can't do anything. So interrupting daily activity. And then headache red flags are like a thunderclap or worst headache of my life, progressively more frequent or more severe, aggravated or relieved by change in position. If they have a history of cancer, HIV, or pregnancy, recent head trauma, onset after the age of 50, and then associated symptoms of like fever, stiff neck, anything that would indicate meningitis, and then associated papilledema or focal neurologic deficits, because that may be indicative of increased intracranial pressure. And then nervous system, so grading muscle strength, which again, we're all familiar with from our assessment video, but we all graded ours 5 out of 5, right? Because everybody was normal, but knowing the abnormals. So like a 4 strength is, they have active movement against gravity and some resistance. And then in grade 3, it's just active movement against gravity only. And then 2 is active movement with gravity eliminated, so just planar motion. And then 1 is barely detectable, and then 0 is no muscular. And then these are another thing that I think are like hot topics on tests is meningeal signs. Like same thing with those, all the appendicitis signs, but meningeal signs. So they have a low specificity, but they're increased when other symptoms are present. So, if somebody has nuchal rigidity, it's not like, oh, they definitely have meningitis. But if they have other symptoms that are cluing you into meningitis, like a fever, headache, then your suspicion goes way up. So nuchal rigidity is kind of just where you flex the chin to the chest, but you want to make sure that they don't have any trauma to the neck first, because you can cause permanent paralysis if somebody has like a cervical spine injury and you go manipulating their neck. So nuchal rigidity, and then there's the Brudinsky sign. So as you flex the neck, watch the hips. And so normally the hips stay relaxed, but if they flex, then that's a positive Brudinsky sign. And then Koenig sign is when you flex the patient's leg at the hip and the knee, and then you extend it. And then if they have pain and increased resistance to knee extension, then that's a positive Koenig sign. And then lumbosacral radiculopathy, lower back pain. There's a straight leg raise test. So this is mostly seen with disc herniations or low back pain with sciatica, which can radiate either down one or both legs. And so to do this with the patient supine, you raise the patient's relaxed leg and then you flex it. And if it's painful, then this is a positive straight leg test. A negative straight leg test makes diagnosis of sciatica unlikely. And then there's lumbar spinal stenosis. And so this is a neurogenic claudication with gluteal or lower extremity pain. And then pain is provoked by lumbar extension, like walking uphill. They may have a kind of like a flex forward posture. And then thigh pain after 30 seconds of lumbar extension. And then the straight leg test is usually negative in this. And then stroke. So cerebral vascular disease, stroke is an acute brain injury caused by a blocked vessel, and it can either be ischemic or hemorrhagic. So ischemic strokes have several causes. Cardioembolic strokes are typically from like AFib. That's why we always anticoagulate the stroke patient or the AFib patients, and so because they're at high risk of stroke. And then large vessel atheroembolic is usually due to carotid artery stenosis. Small vessel withdrawal lacunar infarcts are usually related to like hypertension or diabetes. And then they can have an other cause, including dissection or hypercoagulability, like if somebody has super high platelets or whatever, they can get ischemic strokes too. And then cryptogenic, no known cause. And then hemorrhagic stroke subtypes, so there's 4 types: the intraparenchymal, which is like actually within the brain tissue, and then the subarachnoid, and then the subdural, which is just below the dura mater, and then the epidural, which is just above it. And then early recognition is important in stroke treatment. Because if it's ischemic, they can do TPA to break up the clot. Or I don't know, there's a lot of things that they can do, like the neurosurgery and evacuate clots and things like that. Risk factors for stroke. One of the strongest risk factors is a TIA, or transient ischemic attack. This occurs in about 3 to 10% of patients. Well, 3 to 10% of patients that have a TIA have a stroke within 2 days, and 9 to 17% within 90 days. And then other risk factors are pretty similar to cardiovascular disease. Honestly, if you think about it, if it clogs the arteries in your heart, it's going to clog the arteries in your head too, right? So hypertension is one of the most common risk factors with both ischemic and hemorrhagic strokes. Dyslipidemia, diabetes, AFib, chronic kidney disease, coronary artery disease, sleep apnea, smoking, alcohol, inactivity, weight loss, and diet. And so the stroke warning signs, sudden onset of weakness or numbness of the face, arm, or leg, sudden confusion, trouble speaking or understanding, sudden trouble seeing in one or both eyes, sudden trouble walking, dizziness or loss of balance, or sudden severe headache. And then speech disorders. So there's 2 types of aphasia. There's Wernicke's aphasia and Broca's aphasia. So with the Wernicke's aphasia, it's usually the speech is fluent and rapid, but it lacks meanings. They may just be talking nonsense, but the words are clear. But then they don't understand like what you're saying to them. They're not able to repeat things back. They're not able to name things. They're not able to write. And with Broca's aphasia, your words are kind of choppy and broken up, but the words make sense, but it might just take them a long time to get there and get it out. And then they're able to understand you like fair to good. Repetition is impaired, naming is impaired, but the patient recognizes objects, and then writing is impaired. And the combination of receptive and expressive aphasia is typically Wernicke's. I kind of misunderstood. I kind of thought, if they had difficulty speaking and difficulty understanding, that it would be global aphasia, but global aphasia is the inability to communicate at all whatsoever. And then infancy through adolescence, there was a lot in here, and then like the older adults too, and especially in this chapter because it covers like 3 different sections of the lifespan. So you got infancy, childhood, and adolescence, and assessing all the body parts. So I would just suggest breezing through those chapters, maybe not memorizing everything, but like at least reading some of the things in red there on the side, because there was just there's a lot of information in that chapter. But basically 4 principles of child development is that it proceeds along a predictable pathway. The range of normal development is wide. So I don't know if any of you have kids, but like, they all do things at their own pace. They don't all do, like, not everybody starts walking at 12 months, you know what I mean? So normal development is wide, but typically along a predictable pathway. And then various physical, environmental, social, and diseases can impact development. And then the developmental level affects how you will conduct the history and physical. So how you would assess like a newborn is a little bit different than how you would assess a teenager, right? So keep that in mind. Assessment of children. So you want to perform less invasive maneuvers early and keep the distressing ones toward the end. So, if they're coming in for an ear infection, you probably want to do like everything else before you go look at their ear and upset them. And then if a cooperative child fails standardized screening, refer them for more precise testing or evaluation. And then BMI screening starts after the age of 2 years old. Before that, I think it's like length and head circumference and all this. And then components of pediatric health promotion. So just different things that you might come across, when you're examining a pediatric patient. So you want to assess them for age appropriate development. And then, typically kids come in for well child checks at, specific ages, usually when they're supposed to be meeting milestones or, I think with my kids, like after they turned 5 or 6, then it was every year, but before that it was like every 3 or 6 months or something like that. Integration of physical findings with health promotion, so encouraging kids to, get enough sleep, get enough exercise, eat healthy, and then immunizations are done. Screening, like hearing screening, is done a couple times throughout pediatrics. Oral health is really important. Anticipatory guidance. So, telling caretakers like what to expect, like that. And then partnership with the provider, child, and family. And then again, there was a lot of milestones in here. So I got this little chart, but this is not all encompassing. So I would glance over that chart on page 94-4. I don't think you need to memorize all of it, but kind of have a general idea of when, when kids roll over or when they start to crawl or things like that. But as far as assessing infant birth to 12 months, you want to perform the exam of the infant in the parent's lap. You can use toys to distract them. And then you can ask the parent if they have any strengths or concerns, and then don't expect to be able to go head to toe on an infant. You should just go where the wind takes you and where the baby lets you. And then assessment at birth. So newborns are classified by gestational age and birth weight. And so these help predict clinical problems and morbidity. So birth weight classification, you can see like extremely low birth weight is less than 1,000 grams. Very low birth weight is less than 1,500 grams. Low birth weight is less than 2,500 grams. And normal birth weight is greater than 2,500. So you might have an infant that is, like say their gestational age is like their term, but they have an extremely low birth weight. Then you can't just say, oh, they're a term baby, they're not going to have any problems. Because if they're extremely low birth weight, then they might have problems. So that's why you need to use both of these in conjunction to kind of, kind of guide your care. But anyway, gestational age, preterm is less than 37 weeks. Late preterm is 34 to 36 weeks. Term is 37 to 41 weeks. And then post-term is greater than 42 weeks. And so measurement of growth is one of the most important indicators of infant health. And so variations beyond 2 standard deviations need further evaluation. Like if they're not growing at all, then they need to be looked at, like why they're not growing, or if they're growing super fast, they might have some kind of like thyroid condition, or who knows what. Anyway, APGAR score. So this is a score that is done at 1 and 5 minutes after delivery, and this is to classify the neurologic recovery and cardiopulmonary adaptation to life. So at 1 minute, 8 to 10 is normal, 5 to 7 is some depression, and 0 to 4, you need to begin resuscitation. And then at 5 minutes, 8 to 10 is normal, and anything less than that, they're at high risk for subsequent central nervous system depression or other organ dysfunction. And so this is where the score comes from, this little picture here. So A is appearance or skin color. If they're blue or pale, they get 0 points. If they have a pink body and blue extremities, they get 1 point. If they're pink all over, they get 2 points. Pulse, if it's absent, then it's 0 points. And then if it's below 100, then it's 1 point. If it's over 100, then they get 2 points. And then grimace, that's a reflex irritability. And then, so it's 0 points if they're floppy. If they have minimal response to stimulation, it's 1 point. And then if it's, they have prompt response to stimulation, it's 2 points. And then A is activity or muscle tone. So if they don't have any muscle tone, it's absent, they get 0 points. If they have flexed arms and legs, then it's 1 point. And if they're super active, it's 2 points. And then respirations, if they're not breathing, that's 0 points. And then if their respiratory rate is slow and irregular, it's 1 point. And then vigorous cries, 2. So I would, I guess, be kind of familiar with how this scoring is done, and just recognize that that the pulse, like if they get 1 point for all of these, you need to be working on not necessarily resuscitation, but bringing that stuff up. Okay, and then signs of infant hearing. Okay, so this is just at different ages, like how can you tell the infant is hearing you? Because they can't talk, and I think I always screen the newborns at the hospital for their hearing. So 0 to 2 months, they startle, blink, or calm to soothing music. 2 to 3 months, they have change in body movements or facial expressions with sound, or they'll turn their eyes or head toward the sound. At 3 to 4 months, they'll turn to listen to voices. And 6 to 7 months, they start developing language appropriately. And then risk factors for hearing impairment is if their birth weight was less than 1,500 grams, if they were exposed to ototoxic medications, or if they had infections, hyperbilirubinemia, and meningitis. And then as far as inspecting the ear canal, with infants, it's the ear canal is directed downward. So you have to pull the auricle down and out, not up. And then the light reflex is diffuse, not cone shaped. So you won't typically see that for several months. And then respirations in infants. Increased work of breathing plus abnormal sounds on auscultation are best for ruling in pneumonia. And the best sign for ruling out pneumonia is absence of tachypnea. And then you also want to assess the skin color, nasal flaring or grunting, stridor, abnormal breath sounds, and retractions. And I think, when infants are in respiratory distress, like retractions are really what you see the most. There's a little picture there. It's basically when they're having to use all their muscles to breathe. So you can actually kind of see their ribs because the muscles are contracting inward just for them to breathe. And then primitive reflexes. There's a table in the book about which all these are, but Palmar grasp is like if you put something in their hand, they'll grip it immediately, and that usually disappears by 3 to 4 months. The plantar grasp, the rooting reflex, which is when they kind of like turn their neck to the side, that disappears by 3 to 4 months. The Moro reflex or the startle reflex disappears by about 4 months. And then the asymmetric tonic neck disappears by 2 to 3 months. The Gallant reflex, 3 to 4 months. And then the Landau reflex is about 6 months. So if they're still having these reflexes beyond, the typical time frame, and they probably need to have that assessed further. The parachute reflex actually doesn't appear until 8 months, and it doesn't go away. And then the positive support reflex either develops at birth or 2 months, and it disappears by 6 months. And then the placing and stepping reflex is at birth, but typically is best assessed after they're like 4 days old. And the time frame for it to disappear is variable. So yeah, so variations in these timelines should be investigated for a neurologic cause or muscular developmental issue. So yeah, I'd be familiar with those. And then infant cardiac inspection. So you want to assess for central cyanosis, and this is best seen like in the tongue, the lips, the mucosa, hands, feet. It's always abnormal. And so it's usually a cardiac congenital abnormality or a respiratory disease. And then, so if something's like a true strawberry pink, that's normal, but any hint of raspberry is indication of desaturation and requires urgent evaluation. Because then you're kind of getting like the purplish color, so it's like pink and blue together, so it's purple. And then non-cardiac findings in infants with cardiac disease, you might see like poor feeding, failure to thrive, irritability, tachypnea, clubbing, hepatosplenomegaly, weakness or fatigue. So, like if you have an infant that presents and they're like super irritable, but then they're like falling asleep all the time, then you might want to investigate like a cardiac cause of why that's happening. And then developmental milestones. I couldn't find like a little chart to put on this slide, but there's a lot of them. And so I would look at the chart, 998, 999, and kind of get an idea of, gross motor, fine motor, language, and social emotional skills for those age groups. I kind of just put the 1 and 5 years here. That way, 2, 3, and 4 are somewhere in between there. So like with gross motor at 1 year, they start walking, but by 5 years, they're able to walk downstairs, hop on 1 foot. And then like fine motor at 1 year, they're able to scribble and make 2 cube towers, but at 5 years, they're able to copy triangles and use scissors. For language, they can say 1 word with meaning or point to objects at 1-year-old. And then at 5 years, they can speak full sentences, 6 to 8 word sentences. And then social emotional, like at 1 year, they'll show an object to a parent to share. And then at 5 years, they have friends and they apologize for mistakes. But yeah, again, I would just kind of look over that chart. I don't think you need to like memorize the whole thing, but at least kind of be familiar with all of them. Tips for examining young children. So you'll want to have the parent facilitate the exam. So, they might have to hold the child or remove the clothes and let the child see the tools you're using, so that they're not scared. You don't want to ask them permission to examine. You don't want to say like, can I look at your ear? Because you're gonna anyway, so you want to instead like offer them choices. Like, would you like me to look at your left ear first or your right ear first? And then if you're unable to console them, like give them a short break and then try again. And then you might show them like on a teddy bear or a parent to alleviate their fear. So like, look, I'm going to listen to your teddy bear's heart. And then they can see like, oh, this isn't so scary, and they'll let you do it. Adolescents, health history. So adolescents are more likely to open up when the focus is on them and not their problem. And they're often reluctant to discuss. So, using interviewing techniques, like what other questions do you have? I think another thing it pointed out in the textbook is like, oh, do you have any friends that have these problems? Because if it's, something that their friend has, then it's not so weird and they can relate to it. And then confidentiality. So you might ask the parents to start leaving the room around 11 to 12 years old. Because I guess the thing is that they let teenagers be examined independently. And then there was this mnemonic for like how to get adolescent health history, this HEADS assessment. So their home environment, like who do you live with, like is it safe or whatever, education, employment, like how are your grades, are you working, how's school going, and then eating. You want to ask them like if they're eating enough nutritious foods, and if they have any body image issues. Activities, like if they're doing any activities outside of school. Drugs and alcohol, sexuality, suicide and depression, and then safety from injury and violence, like if they're being bullied and things like that. And then Kanner's stages of development for adolescents. So the definition is pre-adolescent, such as elevation of the nipple only. Stage 2 is breastbud elevation and nipple as a small mound. And then stage 3 is further enlargement of breast and areola, no separation of contours. And then stage 4 is projection of the areola and nipple to form a secondary mound. And then stage 5 is a mature stage. And then the pubic hair development kind of shows like the description for the hair development in there too. And then pregnant women, we're getting there. Okay, so anatomical changes, pretty common in pregnant women. So sometimes they get this striae gravidarum, which is that stretch marks. And then the linea nigra, brownish vertical stripe, like down the middle of the abdomen. And then uterine enlargement, which can cause round ligament pain or urinary frequency. Chadwick sign, which is the bluish color to the cervix due to increased vascularity. And then the Hagar sign is the softening of the cervix. And then breast enlargement and secretion of colostrum, which is the precursor to breast milk. Measuring uterine fundal height. So it just shows you here, like what the expected, if they're 12 weeks pregnant, it's here, right at 36 weeks, it's like right at the cyclic process. It's actually less for 40 weeks. That's what the baby like drops. So the fundal height may be down towards the end of the pregnancy. And then if the fundal height is 4 centimeters larger than the estimated week of pregnancy, then you want to consider a large fetus, multiple gestation, extra amniotic fluid, or uterine glioma. I think most women have like an ultrasound by this point anyway, but if the fundal height is small, then you might want to consider low amniotic fluid, missed abortion, intrauterine growth retardation, or fetal anomaly. I'm sorry. Okay. So components of the initial prenatal visit, you'll want to get confirmation of the pregnancy with like a pregnancy test, determining gestational age and the estimated due date or estimated date of delivery, I think is what the textbook calls it. Symptoms of pregnancy, concerns or attitudes towards pregnancy, past clinical history and past obstetric history, and then family history of the patient and the father of the baby. Not the patient, but the father of the baby, and then any plans for genetic testing, breastfeeding, and birth control after the pregnancy. And then common concerns during pregnancy. It's all combination of like hormonal, fluid changes in the body, anatomical accommodations for the fetus. And then, plus like pregnant women have to take like, prenatal vitamins and iron, which may make them be constipated, but these are some of the common signs of during pregnancy. Abdominal pain, amenorrhea, which, that's all normal, backache, breast tenderness, constipation, contractions, edema, fatigue, heartburn, hemorrhoids, nausea, vomiting, urinary frequency, or vaginal discharge. So, a lot of these you might have to just give them strategies to deal with them, but they're, it's not really necessarily anything wrong. So, hemorrhoids are really common during pregnancy. So, maybe like prescribing like a over-the-counter cream or something like that. And then, nausea, vomiting, like especially in the first trimester, not really much you can do. So, tell light meals, saltine crackers, spray. But then, if it's to the point where they're like losing a lot of weight and they haven't been able to hold anything down for weeks and they're dehydrated, and then you're looking at something like hyperemesis gravidarum, then, then that might actually warrant further investigation and treatment. So it kind of just depends on what it is. Is there anything you can do about it? How severe is it? Kind of thing. So determining the gestational age and the estimated date of delivery. So the gestational age, to do this, you actually count the number of weeks and days since the first day of the last menstrual period. If the actual date of conception is known, like with in vitro fertilization, you use a conception age, which is 2 weeks less than the menstrual age. And then the Nagel rule to calculate the EDD. You do this by taking the last menstrual period, add 7 days, subtract 3 months, and then add 1 year. So 731. And there's a little example of how to do that there. Pregnancy findings. So weight loss due to excess nausea, vomiting is hyperemesis gravidarum. So if it's greater than 5% weight loss, it's associated with adverse health outcomes for the fetus. So a lot of times these women have to be like admitted for, IV fluids and things like that, and IV nutrition. Systolic murmurs are sometimes heard just due to the increased circulating blood volume in pregnant women, but diastolic murmurs are never normal and they should be investigated. And then if fetal movement is not felt after 24 weeks, consider fetal demise or miscalculation of the estimated due date. And then preeclampsia is a big one. This is an emergency, that has poor fetal and maternal outcomes. So it's kind of a big deal. So how this is diagnosed is if you have a systolic blood pressure greater than 140 or diastolic pressure greater than 90 after 20 weeks on 2 occasions, at least 4 hours apart. Or if they have a single blood pressure of 160 over 110 greater than, or with proteinuria of greater than 300 milligrams 24 hours with a protein to creatinine ratio of 0.3 or a dipstick 1 positive. Or if they have new onset hypertension without proteinuria, but any of the following: thrombocytopenia, impaired liver function, new renal insufficiency, pulmonary edema, new onset cerebral or visual symptoms. So that's how preeclampsia is diagnosed. And so if they present with facial edema, especially after 20 weeks, it's suspicious for preeclampsia. And then it increases cardiovascular risk like 8 to 9 times for pregnant women. So very important to treat that. Substance abuse. So alcohol, tobacco, and illicit drug use with pregnant women. So with tobacco, like cessation is the goal, but if they're not able to quit, then any decrease is favorable. So tobacco use is associated with low birth weight, placenta abruption, and preterm labor. And alcohol, there's no safe dose. So fetal alcohol syndrome is the leading preventable cause of mental disability in the United States. So you should use all available resources to get these women to quit drinking while they're pregnant. And then illicit drugs, they should be referred for treatment immediately and screened for HIV and hepatitis, if they're using like IV drugs. And then prenatal supplementation. So daily prenatal vitamins with vitamin D and calcium is recommended. Iodine also, if it's not in a prenatal vitamin, but also more. And then fat soluble vitamins, which are A, D, E, and K, they can cause toxicity. Folic acid supplementation is important to reduce neural tube defects. So folic acid is needed to form the central nervous system in the fetus. So usually that's included in the prenatal vitamin too. And then iron supplementation is needed because the maternal erythrocyte mass increases and it also facilitates fetal red blood cell production and fetal growth. So yeah, women need to take a lot of vitamins to grow babies. Okay, older adult. There was a lot in this chapter too, just about like different findings in different body systems. And so again, I would kind of just peruse the chapter for like the little things in red. There was so much information. So I don't think you need to memorize it all, just kind of glance over it, and anything that catches your eye, just kind of keep that in mind. So key points, so you want to recognize geriatric syndromes and multifactorial conditions. So the most important geriatric syndromes are falls, urinary incontinence, frailty, cognitive impairment. And then the assessment of function, medications, and careful evaluation of risk versus benefit. So if you're going to start them on a new medication, you want to look at the risk and benefit of, like, can this person go without this medication? Like, what are the risks of them not taking it as they get older, just because they're more prone to side effects, and and then older people start getting in all these prescription medications, and it's really a lot. So really doing careful evaluation of that. And then tips for communicating with older adults: you want to use a well-lit, moderately warm, with minimal background noise, chairs with arms so that they can get up out of the chair, and then face the patient. A lot of older patients kind of rely on lip movement to hear you talking, and make sure they're wearing their glasses and their hearing devices. And then allow time for reminiscing and open-ended questions. Don't rush them. And then provide written instructions in large print, like easy to read. And then always give an updated medication list with the doses and the instructions and why they're taking it. A lot of times people don't even know why they're taking medications, but sometimes they'll come in and say, oh, I'm taking this blood pressure medication. So it's important for them to know why they're taking it. And then eliciting symptoms, underreporting. So older adults give more positive ratings to their health due to embarrassment or like fear, or thinking that they're just, that's just part of getting old. So a lot of times they won't tell you about things. And then they often will have atypical presentations. So like, for example, if they have an infection, they may not have a fever. Like you see this commonly, like, they'll get a UTI and they'll get confused, and that's how they present, and that's the only symptom. If they're having an MI, they may not have chest pain, or hyperthyroidism may present as fatigue, weight loss, and tachycardia. So really keep that in mind, that older adults may not be textbook. And then most pain complaints are musculoskeletal, and the American Geriatric Society prefers the term persistent pain over chronic pain. And then special areas of concern. So functional impairments in ADLs. So you want to assess that. Are they able to feed themselves and dress themselves? And even their IADLs, like driving and balancing the checkbook. You want to assess what their abilities are. and if anything is impaired. And then medication management, we already talked about that, you know, sometimes looking at all these medications and saying, do we still really need this because we've got 20 prescriptions? A lot of times they're taking, you know, they're taking medications for side effects of other medications. So really just looking at their medications and making sure they're getting an updated list every time. And then smoking, alcohol, and nutrition, acute and persistent pain, cognitive impairment, urinary incontinence, and falls. Some notable changes in the older adults are systolic blood pressure increases and the diastolic blood pressure decreases, which leads to a wider pulse pressure. And then the JNC8 recommends blood pressure of 150 over 90, but you know, if you prescribe them something and their blood pressure comes down to less than 140 and they're not having any adverse effects, you know, they're not getting dizzy or bradycardic with their blood pressure medications, then you don't need to adjust the treatment. Increased peripheral vascular resistance, and then less compliant, stiffer chest wall, weaker respiratory muscles and diaphragm, decreased stomach acid, decreased gastric emptying time, decreased calcium absorption, decreased concentrating and diluting capabilities of the kidneys, decreased number of renal tubules, decreased T cell function, decreased rate of erythropoiesis. And so this is just like a fraction. There's this huge long table there on page 1163 that goes through like all of the normal physiologic changes with aging, and then the disease processes that you see like as a result of those changes. And so I just put a couple of highlights here, but I would recommend kind of perusing that table because there's a lot. And so, yeah, so continuing on, decreased lacrimation, increased fibrates of the iris, thickening of the tympanic membrane, decreased smell, decreased thirst drive, decreased skin elasticity, decreased number and function of nerve cells, slower neuron function and muscle contraction, decrease in muscle fibers or muscle mass, decreased bone formation, thyroid gland atrophy, decreased T4 production, and decreased aldosterone secretion. So you can see how a lot of those things, you know, lead to the things that we see in older people, you know, like with them getting dehydrated or delayed wound healing, you know, risk of fractures, things like that. So yeah, I would look at that table, kind of just give it a glance over again. I don't think you need to like memorize everything on there, but alcohol use in older adults. So older adults should have no more than 2 drinks per day or 7 drinks per week. And about 10% of older adults in primary care and 38% in hospitalized patients have a problem drinking. So you want to be assessing for that. So screening is important, especially because you know, they're on so many medications, and so you get medication interactions. Like a lot of these say, don't take this medication with alcohol. And then you get chronic illnesses that are exacerbated by alcohol, so like GERD, GI bleeding, depression, gout, hypertension, diabetes. So it's really important to assess for that. And then the CAGE questionnaire is the same, you know, same questionnaire that we use for regular adults. You know, have you ever thought about, you know, cutting down, or are you angry if somebody asked you to quit or whatever? You ever felt guilty? Things like that. So that questionnaire is effective for older adults as well. And then signs of alcohol use disorder in older adults could be like memory loss, cognitive impairment, neglect of hygiene, poor appetite or nutritional deficiencies, sleep disruption, hypertension, refractory to treatment, blood sugar control problems, seizures, and impaired gait, including falls. And then this is a tool that assesses functional deficits in geriatric populations. It's a 10-minute geriatric screener tool. And so first part is the vision. And so you ask them if they have if their vision interferes with their daily activities. And then you do the Snell and eye chart. Hearing, you do the audio scope, and then the leg mobility is the time get up and go test, which is on page 1151. You basically just have them get up from a chair and walk. It's like a race. And then urinary incontinence. So you ask them, have they lost control of their bladder in the last year? And has it been more than 6 times in the last year? And then nutrition and weight loss, like if you've lost more than 10 pounds over 6 months without trying. And memory is a 3-item recall. And then depression, do you feel sad or depressed? And then physical disability, which asks 6 questions about, you know, if they're able to exercise, if they're able to do like heavy yard work, go shopping, go places within walking distance, take a bath or a shower, including like a sponge bath, and get dressed. And so this is a quick little tool that the whole point of it is to see how their functional life is affected. And then there's the 3 Ds with older adults: delirium, depression, and dementia. So delirium is an acute confusional state, and it's sudden onset. It's a fluctuating course, so it'll come and go. And then it's characterized by like inattention and sometimes an alteration of consciousness, like you know, like they're super attended or something. And it's typically in hospitalized patients, which is up to 30% of older adults in the hospital. And then dementia is a decline in memory and cognitive ability, and it interferes with their ADLs. And so some examples are Alzheimer's, Lewy body dementia, and frontotemporal dementia. There's no modifiable risk factors for Alzheimer's disease, and less than 2% have a reversible cause, such as hypothyroidism, hydrocephalus, or depression. And then depression is the 3rd D. So 5 to 7% of community dwelling older adults have depression, and it's often undertreated or unrecognized. And then depressed men over the age of 65 are especially at high risk of suicide. And so using those PDQ questionnaires to screen for depression. And that's it. I took all this out of the textbook. So like I said, there's page numbers there if you guys want to go back and reference it. And here's my email. So you guys can, you know, email me if you have any questions or you know, have any information to add or share or whatever. And hopefully this helps you guys. Hopefully you guys do good on the final exam, and we'll see you soon.